From the Columbia Cardiogenetics Clinic, a genetic diagnosis in a patient without a family history of disease. The role of cardiogenetics in everyday cardiology practice, a case series. Presented by Jessica Hennessey, MD, PhD, Assistant Professor of Medicine, and Natalie Lippa, MS, CGC, Assistant Professor in Genetic Counseling.
Our last case is a young woman, 38 years old, with this kind of weird gradual onset dyspnea, palpitations, chest pain, kind of associated with URI symptoms, but didn't really go away. Sort of weird findings ultimately. And she had a really, really into it primary care doctor who decided to order a CTA because she was a little tachycardic. And I think he was worried about PE at one point with these weird symptoms. And the CTA actually incidentally demonstrated a 7-centimeter aortic root aneurysm and moderate to severe aortic insufficiency. Notably, there was no mitral valve prolapse noted on this or her echo. And she was basically referred immediately to Dr. Takayama, as we all could expect, for surgical evaluation and ultimately surgery with plan for an aortic root replacement and ideally a valve sparing repair. Notably, as far as her physical exam and features, she's 5'11", consider herself very hyperflexible. Was told she had an eye problem at some point, but kind of wasn't sure what that really meant. Has a very high arched palate, no bifid uvula was noted, and had never had any cardiac imaging before any of this. Her systemic score, so the systemic score is a way that we sort of calculate the risk of Marfan syndrome being the true diagnosis based on this. I always say to patients, okay, I'm going to ask you a really long list of questions and go head to toe going through this systemic score, with a score of 7 being effectively diagnostic of Marfan syndrome. And hers was actually only 5, so high, but not fully diagnostic. Notably, she also has a daughter who is tall and thin and hyperflexible. And so, for that reason, one, to understand her etiology, and two, for the understanding of whether her daughter was at risk, genetic testing was performed.
Right. So, in the family history, you can see, right, she has a daughter who's 11. She's kind of 5'7" already, hyperflexible. The proband has a brother, no children, but is doing well. The parents are also healthy, 61 and 66. And then if we go up to her grandparents, one lived to 100, one passed away from an intracerebral hemorrhage, and the other two died for lung cancer. So really no signs or symptoms of connective tissue disorders. There's no other history of aneurysms, sudden deaths, unexplained deaths either. So because of this, the kind of unclear presentation here, we decided to order a broad-based connective tissue panel, given that her score was only 5, and connective tissue disorders can have variable expressivity and reduced penetrance. And so we may have hinted at this already, but we found a pathogenic variant in FBN1, which is associated with Marfan syndrome. This variant is rare. It's a frame shift variant. Loss of function variants and dominant negative variants have been associated with Marfan syndrome. And actually 25% of patients with Marfan syndrome have a de novo variant, which could potentially explain the family history here. It could have been new in our proband. We then went ahead and ordered genetic testing on her daughter, who was found to have the same pathogenic variant. And so this is really going to help her daughter in terms of management, screening. Her daughter was not a competitive athlete, and so avoidance of competitive sports was not a big impact on her lifestyle. But for many other young individuals, that could be a huge issue and something to really work through with the patient. So previously, this patient may not have been offered genetic testing long ago because of that systemic score. But because of these types of cases, the genetic guidelines have been updated to capture these types of patients because of the severe clinical implications.
Yeah, exactly, Natalie. And if you guys saw my talk last week at the Cardiovascular Summit, you probably saw this exact same slide about genetics of aortopathy. But the guidelines were updated in 2022, and this updated guideline really put huge emphasis on genetic testing, particularly for thoracic aortic aneurysm. I'm going to say that again, it's thoracic aortic aneurysm that we're talking about here. Abdominal aortic aneurysms are generally thought to be more acquired in nature, but the early thoracic aortic aneurysms are the ones that we're absolutely talking about. And it was actually interesting. Genetics was in 2 of the top 10 take-home points for this guideline update, which I thought was a big deal considering all the other things that we've been dealing with aortopathy. So I put this up sort of to give you all an indication of reasons why we should actually be thinking about genetic testing for these patients with thoracic aortic aneurysm. In particular, these young onset patients who have features of connective tissue disorders, exactly like this woman was. You know, her just looking at her she didn't really sort of fit that phenotype. But as soon as you see an echo, as soon as you see maybe kind of diving in a little bit more, as soon as you kind of get the idea, oh, you're really flexible, oh, you're pretty tall, oh, your daughter's pretty tall, kind of getting through that, you might have at least ordered an echo, right? And sort of thought about it from that regard, and then move forward with genetic testing if necessary. The other piece I want to emphasize is whether those sporadic sort of patients, those ones who are greater than 60 years old, if they have a family history that still is suggestive of a thoracic aortic aneurysm, it is reasonable to consider genetically testing them or someone in their family potentially who has a stronger phenotype, as I alluded to earlier. And then they do recommend more cascade testing than was previously emphasized. Before, it was basically just clinical screening. Everyone just gets clinically screened, meaning get an echo, get a CTA, get some sort of measurement of your aorta at some point if you're a first degree relative. But now with pathogenic mutations in particular, they're emphasizing more. And again, these are all expert opinion things, but low level of evidence, but high recommendation for cascade screening for these patients' family members.
This was brought to you by the Center for Precision Medicine and Genomics at Columbia. This has been an internal medicine genetics case study.